All right, so I would start by knocking, and then I would introduce myself. Hi, my name is Jenna. I am a student nurse from Oakland Community College, and I would explain that I'm going to do an assessment on the newborn. So I'm going to wash my hands in front of the parents, and then I'm going to put on gloves, and then I'm going to check wristbands. So I would compare the wristband on the ankle, typically on the ankle on baby, to the mom's wristband, and then I would provide a warm environment, making sure my hands are warm, stethoscopes warm, overall environment's warm, just to make it as comfortable as possible for the baby. So I would start with the apical pulse. It's found at the mitral valve, and I would listen for a minute. And the normal range is going to be, it's going to be 100 to 160. Normal is 110 to 160 for an awake baby. If they're crying, it can get up to 180. And if they're asleep, it can be as low as 100 to 120. So it kind of just depends on the state of the baby. So with that, I would then do the respiratory range. Since babies are abdominal breathers, it's easiest to put a finger on the abdomen and watch the abdomen rise and fall. So for the respiratory rate, it's pretty normal for it to be 30 to 60 breaths per minute. So we're gonna listen for a minute. And then with that, we would transition into lung sounds. So I would listen anteriorly. So we have aortic, pulmonic, Erb's point, tricuspid, mitral. And then I would turn baby over, and then I would also listen on the back. So depending on how old the baby is, within the first few hours of life, it's pretty normal for them to not have clear lung sounds. They could still have fluid. So depending on your findings, it could be clear, or it could be a little bit, it could sound like a little wet. They could sound a little bit like congested in their lungs. So findings kind of vary for that in terms of what could be normal for them. And with that, an irregular rate is common, and it's common for them to have apnea or pauses in their breathing because the valves are still closing. So for that, we would look for respiratory distress. For signs and symptoms, which aren't all of them, but some of them would be nasal flaring, and then tachypnea, which is greater than 60, and then expiratory grunting and a dusky circumoral cyanosis. So it's going to be like a bluish tint around the mouth. And with that, we would also note the axillary temperature. So that's going to be, the probe is going to go in the armpit, arm down. The normal temperature is going to be 36.5 to 37.5 degrees Celsius, or 97.7 to 99.5 degrees Fahrenheit. So with that, we did lung sounds, and the lung field, we'll just say we're clear anteriorly and posteriorly. So now we're going to note the newborn's general posture and movement. So is the baby crying, asleep, awake? Are there any tremors? Tremors can be a symptom of hypoglycemia, so it's important to further assess that with a blood glucose test if there was tremors. So pretty much just keeping an eye out for any sort of abnormals and acting on that as we go throughout the assessment. And then we would check the baby's skin color. So are they pink? Is it consistent with ethnicity? Jaundice can be common after the first 24 hours of life, but if it's before then, this is a pretty abnormal finding. We want to notify the provider. So that is one big thing to look out for with jaundice. And then acrocyanosis. So as we were explaining earlier, so sycomoral is what occurs after the first 24 hours, and this isn't normal, and this is the tint around the mouth. But acrocyanosis is when the hands and the feet are bluish, and this is within the first 24 hours. So this is normal. And then I would go ahead and move on to the head. So I'm going to check for anterior and posterior fontanelles. We want to look and see, are they open, soft, and flat? So I would look and assess, and then I go back to posterior. And then typically it feels like a pretty bounding pulse. It's really cool. And if baby's crying, it can be bulging. So that can be normal if the baby's crying. And then with the head assessment, we would also assess for cephalohematoma, and then the caput, I think it's succedaneum. So the hematoma, the cephalohematoma, this does not cross the suture lines. It's a pooling of blood. So you would know if it's cephalohematoma because it does not cross these suture lines on the head. But the caput succedaneum, so this does cross the midline, and it's a buildup of fluid. So that's how you would know if it was that one. So next, I would inspect the clavicles. I would inspect for crepitus, masses, and I would assess if they're intact or not. And the reason why we do this, especially for vaginal babies, is because sometimes when they come out of the canal, it can cause shoulder dislocation. So we just want to check and make sure that they are okay. And then I would also assess the umbilical cord. So with that, we want to assess, and normal findings for that would be 2 arteries and a vein. And we'd also assess if it's moist, if it's dry, or if the clamp is on and off. So with that, we would inspect for signs and symptoms of infection. This could be redness, swelling, tenderness, discharge, or excessive bleeding. And then I would inspect keeping the umbilical cord dry by folding the diaper underneath the cord just so that it can stay dry. And then for the care of it, we'll avoid cleaning it with any sort of harsh chemicals. We would use warm water or a mild soap. So that's umbilical cord care. And then I would also assess the abdomen. So we would look, is it round or soft? Is it round or flat, soft or firm? Is it distended or is it non-distended? And then I would listen. So inspect and then listen. Right lower quadrant, listening to all 4. And a normal finding would be that we could hear all 4 vowel sounds, which is very important. And then we would assess the back. So the difference between babies and us is that our spines are usually straight. That's our normal finding. But for babies, it's kind of in a C shape. So we would assess the back, and yeah, I mean, it helps with digestion, temperature control, and reduces the pressure on the spine and hips, which is very cool. So we just want to assess for that C shape. And then we'll also assess for it's a pilodinal dimple. It's a small indentation at the top of the cleft in between the buttocks, and it's normal in newborns. So we would just assess for that and see if that's there. And then we would move on to genitalia. So for the females, we would want to make sure that the labia majora and minora are present. Slight bleeding and light discharge are normal, and mild swelling is also normal, but we would note if there's a lot of redness, a lot of swelling, so pretty obvious signs that there could be something going on there. And then for males, we would start by palpating the testes, and then if the baby's circumcised, we'd also check for any excessive bleeding or discharge. If there is a whitish substance on the circumcision site, this is normal. It is a part of the healing process, so that's an important thing to note too. You wouldn't notify the provider immediately if you saw that. And then we would also inspect the anus as well, just to make sure everything is intact and dry and clean and all good. So then I'd move on to the reflexes. So we have the grasping reflex, which is when you typically take your finger, because they got little hands, they can't grip your whole finger. So you take your finger and they should wrap around your finger. So that's a normal grasping reflex. And then the startle reflex is going to be when you kind of stimulate dropping the baby, or you simulate it. So you don't obviously want to drop the baby, but you kind of want to do a little, and babies should flail their arms. So there should be flexion of the arms and the legs. So they should respond to the feeling of being dropped. So that would be a normal response. And then we have the Babinski reflex, which is when a finger goes on foot and the toes should fan outwards. And if they fan inwards, this is a sign of a neurological problem. So then this would be something else to report to the provider. And then stepping reflex, so we stand baby up and then they should stimulate walking. It's kind of like like that. Yeah. So that's like a normal stepping reflex. And then for the rooting reflex, we will swipe the finger on the cheek and they should turn in the direction of the cheek that you're swiping. And this reflex reflects the ability of them to turn towards a breast to feed. So those are the reflexes. And then for teaching, so for breastfeeding babies, parents need to know when their child is getting enough to eat. So this can be measured by multiple factors. The first thing is weight loss. So it's normal for a baby to lose up to 10% of their weight within the first 72 hours. And then expected weight gain would be around 14 days. That's when they should get back to that birth weight if they do lose weight. And it is common for them too. So we need to measure their weight loss by weighing them, and then also intake and output is extremely important to make sure they get back up to their birth weight and they continue to grow. So we want 8 quality feedings in the first 24 hours. This can be a lot of different factors, and the way to measure this is mainly going to be measuring the output. So if baby's getting enough milk, there should be output. So for wet diapers, we want 1 on day 1, 2 on day 2, 3 on day 3, and then by day 4, we should be seeing more than 6 wet diapers. And then for stool, we want 1 bowel movement on day 1, 2 on day 2, 3 on day 3, and then after day 3, we would expect to see more than 4. So with that amount, that's one of the big indications on knowing that you're doing quality feedings. So for the characteristics of the stool, for days 1 and 2, we're going to see meconium. It's black, it's tarry. That's going to be the normal finding. And then for days 2 to 3, it's like more of a transitional stool. It's going to be kind of a greenish color. And then for day 7, by day 7, it should be a milk stool. So for breastfeeding infants, it's going to be a seedy, yellowish, whitish color. So that's what the stool would look like. And then for reporting to the practitioner, we did mention the weight loss. So if baby loses more than 10% of their weight loss, or of their weight from their birth weight, we should report that. And then a temp over 99.5 can indicate something like an infection, very important to notify the provider for. And then if their respiratory rate is over 60 and under 30, this can indicate an issue like we talked about earlier. Tachypnea could be a sign of something like respiratory distress. And then if there is no wet diaper or stool within the first 24 to 48 hours, like we talked about, it can indicate poor feedings, among other different things. So we would want to report that to make sure that the baby is getting nutrition. So if the baby is choking, this is a very important thing because it's common for baby to have like some fluid in their lungs if they're still coughing up. And, you know, sometimes it's good take-home advice for how to resolve a choking baby. You just want to make sure that the parents feel confident going home with their child. So you'd want to start by making a C with your hands just to support the neck. And then you would turn them over. And then you would use the bottom of your hand to deliver thrust to the back of the baby. And you don't want to just pat, you want to thrust to make sure that you can dislodge whatever is in their throat. And then for the ABCs, we want to teach safe sleep. We want to prevent SIDS and asphyxiation. So this is going to be alone, on their back, in a crib. So when they say alone, it's more so just not keeping any stuffed animals, blankets, pillows in the crib. And this is why we promote things like the sleep sack, especially where their arms can kind of be out. And then on their back, so when the baby's sleeping in the crib, they need to be on their back. We want them in the crib. We don't want them on the couch or in the bed. And the baby can sleep in the mom's arms or in somebody else's arms, but the person holding the baby needs to be awake. They can't be asleep. And they also should be able to see the baby's face. So they should be able to see a clear space for their nose and their mouth so that they can properly breathe. So this avoids the asphyxiation and the SIDS. So speaking of that, skin-to-skin contact is great. So we want to ask the mom if they want to do skin-to-skin contact. This can promote breastfeeding, the letdown reflex. It can help regulate baby's temperature, especially if their temperature is a little low. We would want to really, really push for that appropriately. So yeah, if baby and mom are doing skin to skin, we would just safely transfer the baby over to the mom. And if not, we would go ahead and swaddle the baby. So now we do arms up and out of the swaddle. And then we take the first corner, tuck it in. Then we take the bottom, tuck it up. And there we go. We have a happy baby. So if we're not doing skin to skin, we're just going to make sure that baby is safe in the warmer. There's no other objects in the warmer. And just make sure everything's all good. And yeah, thank you.